Okay, I think we will get started. It is just afternoon, so we'll get started and hope that others might join us in a little bit. So I am Diane Obey, and I am with the Alberta Spore Support Unit. I'm here today on Treaty 6 territory, and if I can ask you to please reflect on the traditional lands you live on of whether it's First Nations, Inuit, Métis, and recognize that our communities are still enriched by their cultures, their histories, and their languages. And before I introduce our speakers, I just have a couple of housekeeping issues. If you would use the speaker view rather than the gallery view, so that's in your top left-hand corner of the screen. If you would use that, that's easier to follow the speaker. And also, if you have any technical issues, to please put them in the chat or Q&A. The first thing to try actually is to leave the session and come back in again. If that doesn't work, Grace Wang is here to also help out. So the other thing is, if you have any questions during the session, please put them in the Q&A or chat box, and we'll be happy to pass those on to Jeff and Eric. If there's some time at the end, let's hope that they've left us some time at the end. Please turn your video screens off, and we're muting everyone as well. Just this makes for better privacy and also helps with technical issues. So I would like to introduce you to this session on advancing the use of health information in the COVID era. Jeff Bakel is like the two of them, Eric and Jeff, are the ones you want to talk to today or hear from today because they are the experts of data in healthcare research in Alberta. Jeff is the program director for provincial research data services at Alberta Health Services, and he's also got 10 or more years working with health services data and randomized clinical trials. Eric Youngson is the Associate Director of the Alberta Spore Support Unit Data Platform, and also the co-lead of Health Research Analytics at AHS, at Alberta Health Services. And he's also got 10 years of experience in specializing in administrative data. So let's get started. I believe, Jeff, you're starting us off today.
I am, thank you. Yeah, so thanks for the introduction. Yeah, today we'll talk about advancing the use of health information in the COVID era, which we're still in. As a bit of an overview to today's presentation, we'll find out a little bit about you, tell you a little bit about us, talk about some of the new data sources that have come out of our COVID response, look at some of the work we've done as the early response to COVID, which seems like a long time ago, but was not that long ago. And then some of the research we're doing on trials and talking about the near real-time versus refined data that we've been talking about, and Eric will have some information on the patient contact projects we've been working on. So our first thing is we're gonna start off with a interactive question just to see what your familiarity with the use of administrative data is. So there's a link in the chat, I think. And oh, there we go. And then I've got the live results up on the screen. So it looks like it's stabilizing here, and so we've got at least some experience. Everyone's got some familiarity with it, so that's great. And I'll go back. Oh, I guess it's from my slideshow. There we go. Yeah, so about us. So as Diane mentioned, we're the Spore Data Platform. We started in 2012 as a group inside AHS Data and Analytics, and called the Health Research Methods and Analytics team. Since then, it's expanded into the Provincial Research Data Services. And so currently in that group, we've got 25 PhD and master's trained data scientists. So we do a lot of data analytics with partners inside and outside AHS, and a lot of work with with both major universities. We've been doing a lot of work with clinical data, direct clinical data, and of course the administrative data. So currently we run about 200 projects a year, and so this is our sort of, we're the orange group, and that's kind of been our quarterly progress in number of projects since the start. So we often get asked, why are the data considered administrative? And so the first reason for being collected is because they're really part of the business of healthcare. So they're collected, initially for things like, making sure checking hospital volumes, admission rates, that kind of thing. And then, in there, we've been able to leverage some additional clinical information through things like Connect Care. So it's sort of expanded from, really basic counts to now we're starting to get into clinical data and lab data, that kind of stuff. So a lot of the research we do is really leveraging the data that's already collected to answer the research question. So just as a idea where the data come from. So if we take a hypothetical person, call her Mary, say she's 27, just moved from Manitoba. And then what happens when she moves to the province is she gets entered in what's called the registry, the Alberta Healthcare Insurance Premium Registry. And so what it'll tell us is that, she moved in 2012, also give her date of birth, and then give her a personal health number and also a ULI, which is the unique lifetime identifier. So as time goes on, she may stop and visit visit a family doc, get a prescription and some lab work requisition done. So from the physician's visit, we get basically a record that she went to visit a physician's office and submitted a claim, for a diagnosis, whatever the visit was related to, any procedures that were done, and the billing amount. And then when she goes and gets her prescription filled, data gets entered into the PIN data, which is the Pharmacy Information Network. So we get the date, the type of medication, number of pills, that kind of thing. And then same thing, if she gets the lab work done, then every lab test and results indeed get filed into the lab database. And so for us, that creates this, basically we store all this in what's called the Enterprise Data Warehouse. And so as we go through that, we collect the data, like we mentioned, so from the physician claims down at the bottom there, for the sort of general family doc visits is kind of the easiest one. And if we kind of work counterclockwise, we collect some data from the census we can link in to give socioeconomic status by postal code. Vital statistics gives us kind of the birth date, moving type information, and death. And then we also have the perinatal health, which provides basically a record of birth from any babies born in the province and some initial data from there. We have our HealthLink data, so there, someone calls 811, we get some information from that. Pharmaceutical claims for the community pharmacies, lab, and our diagnostic imaging data. And then also we have data from the in-hospital world in terms of what's called the discharge abstract database, which kind of reduces basically reduces a hospitalization down to a line. So we get admission, discharge dates, reason for admission, any procedures that were done, and we can link that to the admission, discharge, transfer to tell us whereabouts they were in the hospital and that kind of thing. And I put sort of the Connect Care off to the side here for now, because that will give us some additional clinical information for anyone in a hospital outpatient. And kind of continuing, we've got our outpatient data, which gives us our NACRS, which gives us sort of the outpatient specialty clinic data, any ED data. Again, usually the interesting things there are the times, diagnoses, procedures. And then we kind of get into long-term care and our patient survey data, which is some of it is updated quarterly by any of the EHS facilities. And then we can, we've also been linking to the EMS data, which isn't technically stored in the warehouse, but it's a set of data we can link to, which, you know, inside AHS and provide research on. So that we can look at some of our early response to the current pandemic. And so early on, I think folks may remember there was lots of activity around building mathematical models for, you know, infection rates and that kind of thing. And so early on, we'd spent some time there. We didn't have many cases in the province, and so we were looking at, you know, basically these types of mathematical models where we had, you know, a susceptible population, those who were exposed, those who were infectious, and those who were recovered. So it's kind of the SEER model. You know, as we sort of went through this, we started to figure out, you know, that the models were very sensitive to the parameters that were involved. So we ended up with a lot of, you know, lots of different models. Some were terrifying and some were, we were going to be fine. And then, but, you know, we were able to base some initial models and decide, you know, and determine things like closures, you know, closing schools and all that sort of stuff that went on early on. But we've, as time has gone on, we've seen how sensitive the infection rate can be to these individual models. So for us, once this started, is we started getting additional feeds from the lab for the diagnostic test for the, if people have had a swab test from the drop-in centers, and also the and then so the positive tests are, and the work done by the contact tracers is all kept in what's called the communicable disease outbreak management system. And so that keeps some of the symptom data and information around infection date, location, and cases that it's tied to. And so we started getting those in through our warehouse, which kind of brings us to this sort of notion of near real-time data, which sounds really great and like the sort of thing we want. But you know, what we found is that as this has evolved, we've had, you know, lots of noisy changing fields and table names at the start, you know, because our systems weren't really set up to do this. We had lots of data revisions. So you'd look at the data one day and then it would, you know, say one thing, and the next day it would say something different about the same day, which we're not totally used to. And then we've had lots of changing tables and contents. And then, you know, the other thing is that we've had lots of systems that were overwhelmed. And so the picture is the boxes of files from one of the 811 call centers. So what happened there is that usually they would be entered into a computer, you know, directly into a computer database. But since they were overrun, they ended up just filling them out on paper and then putting the paper in boxes. So one of the projects that's come out of this is where we're looking at scanning all these things and trying to do some optical character recognition to pull as much information as we can from the files. And so that picture is just from the Edmonton Data Center, and there's a second center in Calgary. So I think there's a total of 174 boxes that we have a couple people working through. So on the AHS side, there was a emergency coordination center formed, and again, we were looking at the early warning system. Well, we were looking at the early models and decided that they were a little too unpredictable for planning. So we went to basically development of an early warning system by another analytics group. This wasn't us, but our colleagues. And, you know, some of the decision was made to basically be able to look at, you know, we decided to look at a 2-day or a 2-week forecast rather than trying to expand too far ahead, just given all the unknowns that were there. And so this, we were able to build in some additional, if you look on the left, additional stages. So if hospitals were closed or purposed differently, and then a few models. On our side, and this Tableau was actually developed by Grace, and so we've been tracking and monitoring the cases, and then how many end up in hospital, recovered, and then in the ICU. And so this has been able to help start some of the work in predicting who would end up in the hospital, what comorbidities are predictive, and kind of keep a monitor on the situation. So from the research side, there was a call in April for COVID research projects. And so there were hundreds of applications in the province, which we were supporting getting the applications in, and then now we're supporting the ones that were awarded. And so what we found, is that the research community is looking for all kinds of things from this. Both the lab tests that we've got, they're looking to link it to DNA, serology, imaging, want to do interviews with patients, have them fill out questionnaires, conducting lots of machine learning stuff. And then there's lots of interest in the movements and actions of people. We've had a few ask for data from the Tracer app, which we don't have yet. And so, there's been all this drive to do this research, and it's really run us into a privacy issue. And so, because COVID-19 is considered a communicable disease and it falls under the Public Health Act, we found there are some different legislations and different legal issues than we're used to having. Usually our information we would send out or disclose would be through kind of guided by the Health Information Act. And so we've been spending a lot of time to figure out how to get those two to work together so we can release data to researchers. I think we've had some recent advances in that, so we've sort of found a way forward, I think. And I thought when we signed up to do this talk, I thought we'd be further along than we are now, but here we are. But yeah, so with the Public Health Act, there are additional protections on communicable diseases because it was built with things in mind like HIV, sexually transmitted diseases, and things that we usually want to keep a lot. Both patients and providers and everyone wants to keep a little more privacy on. And so, we've kind of been working through that. It is different because of the higher rate of incidence, and maybe has a different social component to it. And so with that, I'll ask our second question, which is how do you feel about your data being used for research? So hopefully that's in the chat. So that looks like it's stabilizing. So looks like people are pretty comfortable with AHS or government using the data, which is good. Lots of confidence in their university research community, and less so in the private companies. Those results are probably not that surprising. And so with that, I think I will turn it over to Eric who will talk about some of the specific projects we've been working on.
Hi, thanks, Jeff. Just gonna get my slides going here. All right, hopefully you can all hear me and see my slides. So I'm gonna start by talking a bit about impact of COVID on other research that was and is happening in the province. So this is a little bit of a screen grab from an article that is actually not fully showing properly, but essentially there was an article published in the New York Times in early April. It's kind of saying that because of COVID, it's kind of this global pandemic, and researchers across the world are just kind of breaking barriers and starting to work together, even though they don't normally do this, and they're trying to find a vaccine and other cures. Just the article is that everything's moving to focus on COVID, and every other piece of research is grounding to a halt.
Sorry, Eric, I'm going to interrupt
yeah.
you for a sec. We cannot see your slide. So if you want to try sharing your screen again.
Yeah, let me try that. Let's see. How about now? Is that better, Diane?
Yep.
All
yeah.
Right. Sorry about that.
If you want to put it on full screen mode.
Yeah.
Great.
Okay. Yeah, so as I was saying, the gist of this is that they were saying, article saying that other research was ground to halt because of, everyone moving to focus on COVID. I guess our interpretation of that is that, well, that's actually not true at all. That's not what we experienced. Oh, sorry, here's the other part I was looking at. Sorry, it's in transition. So essentially, yeah, the bottom line here, it's, nearly all of the research has ground to a halt. And for us, we look at that and we say, well, no, not actually at all true. If you look at it, this is a quick graph of the request volume that our group within AHS, our specific sport data platform group, the request volume over the past few years that we see or have seen. And so the red vertical line essentially representing, when the kind of lockdowns in Alberta started in, March. So the second last point is kind of mostly pre-COVID and, kind of just catching the tail end of the start of COVID. And then the last dot on the right is, the 3 months after that. So, April, May, June. And while there was a decrease in our request volume, it really wasn't anything unexpected. It's in line with previous years where we saw a decrease in that quarter. So, we really, in our area, which is mainly working with the administrative data, we're not working on, kind of vaccine research and that kind of, in the lab stuff. But for us, we didn't see this, we really did not see this halt of other research. I think, there was some stuff that, because of university shutdowns, maybe slowed down for a little while, but then at the same time, people working with admin data studies, they're not in a lab, they, they're working remotely. So there's no reason they couldn't do this from home or, wherever they were still working. So we didn't experience that. And so our other work kind of kept up as it was for the most part. So we were kind of balancing this new COVID work and our previous work. So next we're going to talk about patient contact for study recruitment. So a lot of our, a lot of our core work in our group focuses on the administrative data, and usually that's kind of building out cohort studies using only administrative data. But it's actually pretty powerful in that we can also use this to help recruit patients for prospective studies as well. So we're not necessarily relying on only administrative data. And so, I mean, this is important because it allows us to help facilitate patient involvement in research studies. Because admin data is great, but it can't answer every question, and there's some limitations to what you can do with it as well. So in terms of these types of studies, some examples, they could be a survey, as Jeff mentioned, maybe some like imaging or biomarker studies where you want to, people to come in and you do some tests with them. Even interventional, clinical trials. We've done some assistance with those as well. We're going to talk about one of these in a couple minutes as well. So in traditional patient recruitment, patients would be recruited from the circle of care, and so either maybe it's the patient's physician who is aware of a study and thinks the patient might be, a good fit or eligible for various reasons, or traditional advertising where you have posters up in, doctors' offices or, wherever appropriate places are that people may see these posters and, kind of take a pull tab and call in and say, hey, I'm interested, tell me more about the study. I think in the best of times, especially the kind of poster type advertising isn't particularly efficient. And, now I think is even less efficient. That's just anecdotally, we believe is less efficient because you have people kind of going, less out and about, less, in-person visits because there's some, virtual visits happening and reasons like that. So I think it's even harder to recruit patients for studies. So important to note that, there are privacy restrictions that help guide what can and can't be done with this. So essentially, like, we are not going to just send a list of patients to a researcher at a university and give them their names and phone numbers and say, here, call these people and see if they want to take part in your research. That strictly does not happen. So what we've done is we've helped to develop a process that enables Alberta Health Services. So, I mean, we're the healthcare delivery organization, so that AHS will actually contact the patients instead of and not the researchers. And then, I mean, so we'll talk about the flow a little bit right here. So essentially, what would happen is step one, we will help to identify people who, might be eligible for a study. And, usually it's pretty high level at this point. So, and we're using the data warehouse that Jeff talked about in detail earlier. So for example, maybe there's a study and they want to identify people who had tested positive for COVID. They were adults. Of course, we're only going to contact people who are alive. We don't want to, send letters to people who have passed away. And, maybe there's specific geographical areas that are a focus for a study, and, any other criteria that we can do relatively easily with our data. So first we'll identify those people. And then the second step would be to actually contact these people. So this would not be our group. We're kind of the data people. But there'd be another group who will help contact these people. And so again, this is being done within AHS. So the two main methods, I guess, that would be used are either mail or phone. So if it's mail, there'll be a short letter that would actually be mailed out to these people. If it's phone, and phone is more rare, but there's been, one or two instances of using this where you'd actually call the people. It's typically when it's very, time sensitive for recruitment into a study. And then important to also note with the contact piece that if someone requests that, they don't want to participate in, maybe they're not interested in this one study, but they also don't want to participate in any research, they can tell us, say, you know what, I'm not interested in research, don't ever contact me again. And we'll respect that, and we'll add that to our do not contact list to make sure that we're not, inadvertently bugging people in the future for other studies that they may also be contacted for. So after people are contacted, essentially the AHS staff, whether it's mail or phone, it tells them a bit about the study. It doesn't give them all the details, but it gives them enough that they get a bit of an introduction to what the study is about. And then if people are interested, then they can enroll in the study. And so in the example of a mail out, someone receives a letter, that's kind of the end of the involvement of AHS at that point. If they're interested in the study, they can then contact the research team directly. So, I mean, they'll be, whether it's through email or a phone call or whatever the study team has put in that letter, then they can contact the study team, learn about all the details of the study, kind of the inclusion exclusion criteria, whether they're, they may not actually be eligible for the study because there may be some, criteria that they don't actually meet, but can learn about all the details. And then if, they're still interested and they're still eligible, then they can enroll in the study and provide consent. And then at that point, they're working with the research study team. So, I mean, that's typically, university and investigators who are running the studies. And then, so, I mean, once someone's enrolled, then the last step is to actually implement the study. And so that's, a pretty broad category, but, whatever the study is doing, it could be a drug intervention. It might be testing where they go and get blood work done, or, it could be as simple as filling out a survey and mailing that back to the research team. And, I didn't cover it in here, but, you know, like Jeff talked about privacy, and of course, like one important aspect about any study is that everything undergoes ethics approval. And so, you know, there's research ethics boards in Alberta that review these studies and make sure that ethically they make sense, or not they make sense, but that ethically, you know, it's appropriate to conduct the study. And so that, you know, that happens early on before any of the actual, you know, study or any of this process takes shape. So a few other considerations for these types of studies is, you know, expenses. You know, there are expenses in phoning people and mailing out letters to people, and you know, that's in terms of us doing work to, you know, help identify potentially eligible patients and the actual, you know, sending out letters. So there are costs, but in general, I mean, there's, you know, higher recruitment numbers compared to, you know, posting you know, putting a poster up in a doctor's office or something like that. Language barriers, you know, that's something that, you know, is a factor for sure, just because, you know, not everyone has English as a first language or strong English skills, but typically, you know, the phone calls and letters are going to be in English, so that would be a barrier to reaching people. So multiple contacts for patients for various studies. You know, we try to be very careful to make sure we're not, you know, hounding people and, you know, every week or month or even year they're getting letters for different studies. Just, you know, we want to respect people's, you know, kind of time and privacy. And then the ability of study teams to respond to patients. We want to make sure that if we're sending, you know, thousands of letters, and suddenly a study team gets, you know, a whole bunch of responses back, that they can actually handle this, you know, this volume. And so sometimes, you know, may mean that we're sending smaller batches of letters to make sure that they're staggered out so that, you know, a research team isn't overwhelmed all at once. So that's kind of our overall process. So now we're going to talk about a specific study that we helped with, and this was very early on into kind of the COVID pandemic. It was called the Hope COVID trial in Alberta. And so, I mean, some of you may have, or, you know, probably will have heard about this. It was, you know, a high profile study. It, you know, had some media attention. It was on the radio and the newspapers. And so essentially it's a clinical trial that is underdone in Alberta to investigate the effectiveness of hydrochloroquine, or HCQ. So this is you know, a drug that I guess kind of famously President Trump in the United States had touted as being a cure for COVID. And you know, and I guess so early on it had a lot of media attention, you know, both kind of good and bad. And so it's a randomized, double-blind, placebo-controlled clinical trial. They were looking to recruit over 1,600 people who had tested positive for COVID and were in the community. So they not people who had been hospitalized for COVID. So kind of the, you know, less severe, you know, someone who tested positive, but they're still able to be at home and recover. And the treatment, they were doing a 2-to-1. So I believe it was for two, they would give, so 2/3 of the people who enrolled would get the actual HCQ study drug, and 1/3 would get a placebo drug. And it was province-wide. So anyone who wanted to, you know, who was eligible and ended up enrolling in the study, they would courier the drugs to them wherever they were in the province. So they didn't need to come to, you know, Edmonton or Calgary for this treatment. So, you know, the studies, I guess one of the main initial barriers that the study faced was how to actually get people to learn about the study and, you know, potentially enroll in this study to participate. You know, there was no practical method for them to actually, you know, get people to enroll in the study. And so our group was approached to see if we might be able to help. And what we ended up doing, and so we'll talk about the process. Essentially, we followed that generic process we just talked about. And I'll go through some of the specifics for this study in the next slide. And then in addition to helping to, you know, identify and, you know, patients for potential recruitment, and we also helped with defining outcomes for the study. And so some of the main outcomes we wanted to look at: mortality, whether someone ended up being hospitalized for COVID, and, you know, then within there, if someone ended up being admitted to an intensive care unit while they were in hospital. So those were kind of some of the main outcomes that they were looking at. And so we were able to help with that with our administrative data as well. And so the process that we followed here. So step one, we identified the people. So we would identify who had tested positive, make sure they weren't currently in hospital, exclude anyone who was under 18 years of age. And just remind at this point, all this data is within AHS. We're not releasing any of this data outside of AHS. It's all securely within AHS. And then in the second step, people would actually be contacted. And so in this case, this was being done every day, where every morning we would run an extract. On our end, it was automated. We'd have an automatic process that runs an extract, identify the people from the, essentially the previous day who, meet the criteria. And then there were people within AHS who would call these people, and they'd, tell them a little bit about the study. Again, it's not every detail about it, but just enough that they get an idea of what it's about. And then if the people were interested in learning more about the study, their information was then allowed to be passed on to the research study team. And then the research study team could actually call these people because they provided that initial consent. So then they would call the people and see if they're interested in enrolling in the study. There were some other eligibility criteria that we applied. I mean, kind of some certain drugs that they wanted to make sure people weren't on, so we could identify that using our pharmacy data. We excluded people who were known to be pregnant because they weren't eligible for the study. So, a few, and I guess one of the main criteria actually was timing. They wanted to make sure that people were recently diagnosed with COVID. So we had a criteria that it needed to be within a few days of them testing positive. So that if for some reason there was a delay and, they tested positive 2 weeks ago, but they just got into the system, yesterday, or their symptoms started 2 weeks ago, we didn't want to include those people because they were, too far along from when they had first been diagnosed or the symptoms started. So we excluded those people as well. So then in step 3, the research team will contact those people who provided their initial consent. They'll go through, telling them about all the details of the study, a very detailed eligibility criteria. There's certain, pre-existing conditions that, would make people ineligible. And then, so if they were still eligible and they were still interested, then they can actually enroll in the study and provide consent to be part of the study. And then, they would actually be randomized to either the HCQ drug or the placebo. And, we sent that drug and then presumably, take the drug for the, the recommended regimen that was part of this trial. And then the last step essentially is, follow these patients to observe their outcomes. And so this was, mainly done by the research team. They would have patient contact, so they would, call the patients to follow up with them. And also, kind of get check patient medical records. And then, as mentioned, we helped with this as well by pulling some of our administrative data to get, kind of the mortality and hospitalizations and emergency department visits, because it was pretty easy for us to help with that and save some time for the research team. So the results of this study, overall, about 2,500 people were called. And so, I mean, a bunch, so it sounds like a lot of people that were initially called, but in the end, only about 150 ended up enrolling in the study. So really low numbers when they were looking for, 1,600 people to enroll, and they got less than 10% of that. And then what happened, I mean, I guess a few things happened. In May, there was a study published in the medical journal Lancet. And this study suggested there was no benefit and even potential harm for this drug for treating COVID. And this caused this trial and many others around the world to be paused while, kind of whether the safety was evaluated to determine whether this was even any point in considering these other studies. This study was later retracted due to some major issues with the study, but at that point, kind of, these studies lost momentum. And, also there were too few cases at that point in Alberta to really be practical to recruit, because the numbers had started to decrease a lot at that point. But so even though there haven't been any, even though that study was flawed and there haven't been any really important results published from this study, other studies around the world have shown that there is, likely no benefit for this HCQ drug and even potential harm. So even that first study had issues, other studies have since been published to suggest that as well. So that's kind of our main portion of the talk here. Just a few conclusions. Obviously, it's been a challenging time for many reasons, and I think that the same reasons that everyone has been experienced. Kind of working from home when possible, and mental stress of working in a pandemic, as well as a lot of the data issues that Jeff mentioned, where you're kind of working with this near real-time data and new data sets and data changing constantly. So there's been challenges. We're slowly starting to resolve the privacy issues that will better facilitate COVID data to be used for research, while of course respecting the Public Health Act and everyone's privacy. There's certainly important research that continues to be carried out that will help Alberta and globally better understand COVID-19, and we continue to balance COVID-19 and other research priorities, because certainly COVID hasn't caused other research to stop. So that's the end of our kind of formal presentation. So I believe we're happy to answer questions. Diane or Grace, feel free to jump in if there's facilitation that needs to happen.
Diane, is there anything you want to say before I throw questions?
I will defer to you, Grace. You have the questions, but and I will thank Jeff and Eric once they answer the questions.
Okay, so we actually still have lots of time. So if you still have any questions, you can ask them in chat, and I will throw the questions to them. And this is a great time. You can just ask anything. I actually have like a couple of questions that I was asked before, but I don't know how to answer. So this is a great chance. The first one is in Alberta, who can use administrative data? Like everyone's talking, like researchers can use them, but how do you define researchers? And there was a time I was asked, it's just a patient who's saying, I think I want to do some research to find out an outcome of a surgical procedure my doctor recommended me to do. Can I claim myself as a researcher? So who can use administrative data in Alberta?
That's a good question for sure. So I guess, typically researcher means that you're affiliated with, an academic institution. And then from there, then you need to apply for, research ethics approval. And I guess one of the main reasons for that is really because of privacy and underlying agreements that are in place. So, like we don't, like the data that was being used for research, we're not releasing most of this data publicly because there is always some level of, privacy risk and, identifiable risk. And so when we release data to a researcher at, say, the University of Alberta, there's an underlying legal agreement between Alberta Health Services and the university that allows us and facilitates us to actually, send them data. And so, essentially for that to happen anywhere else, there need to be a legal agreement in place for that to happen. And so that's why it wouldn't really happen for, sending it to a person who's not affiliated with an academic institution, because these legal agreements aren't in place for that to happen. So I hope that mostly answers the question.
So like, are there any other places they can find information like that?
Well, I mean, there are often, I guess, depending what it is, there are sometimes reports that are, published by Alberta Health Services or, Alberta Health, the government, even other organizations like, so the Canadian Institute for Health Information is a national organization that they kind of harmonize some data between the provinces and do a lot of detailed reports that rely on administrative data. So they are often a really good resource for health data in Canada. And I mean, otherwise, I mean, I think you're really looking for other research that's been done by researchers, whether it's in Alberta or Canada or internationally.
Okay, thank you. So the second question is, who is mostly using the predictive data and for what purpose? How are you sharing it? And I guess that actually refers to possibly the dashboard you shared about all those predictives.
Yeah, so the predictive data and the dashboards that we've created so far have pretty much entirely been used for the provision of health service in the province. So they're mostly used by AHS internally. And then I think there's, as we sort of work out the privacy side that keeps coming up, is that then we'll be able to, sort of leverage that data for some of the research projects. So again, all the stuff we've used at the initial stage, especially, was really operational planning, real business healthcare stuff.
Okay, and there are also questions about the especially during the COVID period. So what are the individual roles of Alberta House and HS and when it comes to the COVID response? Because you can find information on Alberta House website and also on HS, and like what are the different roles of them?
That's probably a talk of its own, but it's really the AHS is mostly concerned with, right, the sort of acute care side, and then I would put the Alberta Health as more on the larger surveillance. They've been taking up more of the larger sort of, population level surveillance work. I think both have a role, and I mean, we work very closely together. So, and all this is very related, right? If there's lots of cases in the community, then it's going to affect the hospital systems.
Always helpful to keep in mind that, like Alberta Health Services is kind of the healthcare delivery organization, like Jeff said, kind of the acute stuff, right? Like, so they're doing the testing for COVID, but Alberta Health, the government, is more the, the top-down policy that's guiding a lot of this stuff, right?
And most of this falls under the Chief Medical Officer of Health, Dina Hinshaw, who is sort of outside either organization. So, right, it's its own office.
Okay, so the next one, do you know like how the administrative data is used in the other provinces in Canada? Like, do they have the similar system like the Alberta House and HS, and like do they all have like sport platform, something like that?
Yeah, good question. There are, I'd say the other provinces are very similar in terms of how they use the data. There are definitely differences in how they are structured though. So every province, or at least most provinces, have, SPOR support of some kind, but they're not necessarily structured the same way that we are. I think we're pretty unique in that, kind of our SPOR data platform is situated within Alberta Health Services. In other provinces, for research using administrative data, there often is a separate organization that actually facilitates that. So just an example, like some names that may be familiar. In Ontario, there's an organization called the Institute for Clinical and Evaluative Sciences, or ICES. And so they, they're not part of the government, but they have, they have agreements that allow them to work with all of this administrative data, and overall pretty similar to what we have in Alberta. And so researchers there would go through ICES for administrative data research. Similarly, in British Columbia, there's a group called Pop Data BC, and same idea. They're not the government, or kind of the government delivery organization like us here in AHS, but they have access to the very similar data. And so, yeah, I'd say a lot of the data is pretty comparable across provinces, even though there are some differences in how it's collected and how it's used. And there's actually, as part of SPOR, there's actually a fairly recently started a Canadian data platform, or CDP, and a sub kind of group called DASH, the Data Access Support Hub. And so our group sits on that national platform. And the goal of that national platform is to help facilitate, administrative data research across Canada. And so it helps to give a central intake spot for researchers who want to conduct research across multiple provinces, where they can go to one spot. And this group is not a group that's going to have data from every province sitting in the same repository, but they can help navigate the process within each province and help facilitate getting access to using national data, or these data from multiple provinces for a research project. So there's definitely some progress in that respect that's happening.
Okay, so I don't see any more questions. So you still have a minute to ask. But other than that, thank you very much. And Diane, you can take it over.
Sure, I do see another question. Do individuals give permission for their information to be used to establish the initial contact? I think that came around when you were talking about the HOPE trial, or whenever you do make that initial contact.
Yeah, so I like the initial contact that's done by AHS. People have not provided explicit consent for that. But because that's being done by AHS, it's kind of being done by the healthcare delivery organization, that's okay. But as kind of we mentioned, like you'll never be contacted by a researcher without first providing that initial consent that happened through AHS. It's like we're not just giving your names, we're not just giving anyone's names and numbers out to researchers to contact people themselves.
Good. Okay. Unless, Grace, you see any other questions. I'm not sure why my video is not showing up when I'm talking. I apologize for that. But I do want to thank Jeff and Eric for your presentation today. I found it, quite interesting, because I see how much work goes into that recruitment and how much you can help with recruitment and establishing the criteria too, which can be quite complex. So it was very, very interesting to me. So those of you who might have missed part of it, or who are having trouble viewing some of it, thank you for attending, but you can also get the recording. It'll be available on Whova within 24 hours. So don't forget, this afternoon we have our studentships presenting if you want to attend that at 2:00 Mountain Time. It would be great if we had a lot of people coming and supporting them, just to learn about what they're doing. Our studentship awardees who are going to present short posters on what they are doing in patient-oriented research. So thank you very much, everyone, for attending, and look forward to seeing you either at the end of the week or next week for the next sessions.